My name is Abigail Wilpers, and I am an assistant professor at the University of Pennsylvania School of Nursing, and I have a joint appointment at the Children's Hospital of Philadelphia Research Institute. And I am here talking to you today about work that I do, which is focused on how we care for pregnant people whose pregnancies are complicated by a severe fetal condition, and how we provide person-centered care to those families. Every individual and every family are different. Some families, when they find out that their fetus has absent or non-functioning kidneys, may choose abortion care in the hope of protecting their baby from suffering after birth. Others may choose perinatal palliative care in the hope of a compassionate death in the loving arms of family. And others may choose intervention before and or after birth in the hope of giving their baby a chance at a longer life. As you might imagine, the conversations with these families then really have to be different, and the services that they might access and desire are also going to be very different. And so we can't deliver standard counseling, we can't deliver standard services. And that's where person-centered care comes in, which is care that is respectful of and responsive to individuals' preferences, needs, and values. So when we started this research, we started by digging into what kinds of evidence we could find about how person-centered care is being received in these fetal care centers. We know that person-centered care in other areas of healthcare has been associated with better experiences of care, better outcomes. And so what does this look like when it comes to people who are dealing with pregnancies complicated by a fetal anomaly? And what we found is plenty of positive evidence, certainly, about people's experiences with fetal care centers being really, really welcoming and being really careful to tailor the care to the pregnant patient's needs and following up with the patient even after a loss, and really people talking about how sometimes these care teams become part of their families. But we also found areas in need of improvement. Some of those, in fact, most of those, were really focused on communication. And so that's one of the things, even though as clinicians, that's one of the things we all do the most, it is in fact one of the things that we get the least training in. So being able to provide care to any family that walks in your door, no matter what their preferences, needs, and values might be, and finding out what those preferences, needs, and values are, can be very challenging and intimidating, and is likely why we've seen that clinicians going into this field have reported feeling unprepared to have these types of counseling conversations with families. For example, we have seen evidence where a clinician is attempting to say something reassuring to their patient who's trying to make decisions about a complicated pregnancy, and they say something like, "You can always have another baby." Now, unfortunately, we know that that kind of response can cause psychological harm. But again, there are so many different clinicians seeing these pregnant patients now. You have pediatricians, obstetricians, surgical interventionists. These are all people who are going to be talking to these families about what their options are, about what their future might look like. And so they've not gone through a standardized training for how to have these conversations. And so that's one area of person-centered care where it can be very challenging if assumptions are made about what the pregnant person is thinking about their pregnancy in terms of whether you use the term fetus or baby, or whether you ask if they've given a name. All of those things can be very value-based and can have an effect on someone. Similarly, continuously asking, since these patients see so many different providers, if every single provider reminds them that they could have an abortion, even if they've said to one provider that that was not their care choice, that can feel like they're being pressured. So how do we get the sense of what the preferences, needs, and values are, and then adjust our care and our care systems to meet them where they're at and meet their needs? I would love to say that there are enough fetal care centers across the country to be able to provide this kind of holistic, coordinated approach to every family. However, there are going to be many people for whom accessing these kinds of resources is very challenging or next to impossible. So folks who are living in rural areas and may not be able to travel to where most of these centers are located in major metropolitan areas. For some people, the ability to take time off of work or have someone care for your children at home in order for you to travel long distances or be able to undergo some of the interventions that are offered, unfortunately is not realistic. So while I'd love to say that we are providing this kind of care equitably across the country, unfortunately we are seeing some major disparities in who has access to the care, what kinds of experiences people have, and their outcomes. And so this is another area where person-centered care really needs to be looked at carefully. I think the most important message that policymakers could take from our findings are in the words of the participants, are in their poignant descriptions of their experiences, and how many of them don't reflect what we're seeing in the reproductive laws that are being passed right now related to restricting reproductive services such as abortion care. So I think looking at how actual people go through these experiences and what they say should be what inform our laws, and we have some robust data here that can be used by lawmakers to better understand the human experience of a fetal anomaly.